Thank you very much for the introduction. I want to thank Dr. Alaskar for the kind invitation to be here. It's my first time in Saudi Arabia, so I'm excited to be here to introduce you a very interesting topic, which is the geriatric hematology. How can we adapt the therapy to our older patients with aggressive malignancies? And I'm going to be focused in patients with aggressive lymphomas. To start, I'm going to give you a very brief introduction about geriatric hematology, which is a relative new field of study, which is focused in older patients with hematological malignancies, and it has one aim, which is to tailor therapy and individualized patient's care. Dr. Lodovico Balducci is an Italian hematologist who is based in the United States and is considered the father of the geriatric oncology. And he first stated this difference between biological versus chronological age, because they are different. Aging is associated with a common trend that include a decrease in functional reserve of multiple organs and systems, and it is associated with an increased susceptibility to diseases and injuries. And chronological age must be used as a landmark in order to identify the physiological age before starting any chemotherapy in our older patients with hematological malignancies. And this landmark age must be at 70 years of age. Why it is of relevance, the assessment of the biological age? Because population in the world is aging, even more in developed countries. There is a higher incidence of hematological malignancies in older patients, and there is also a higher mortality in older patients with all of hematological malignancies. And as an example, in the United States, cancer is one of the top 3 causes of deaths among people aged among 70 to 90 years old. If we have a look at lymphoma data, in the last update of the National Cancer Institute statistics, you can see that the median age at diagnosis of non-Hodgkin lymphoma is 66 and is most frequently diagnosed among people aged among 65 to 74. But if we pay attention to the mortality related to lymphoma, the median age rises from 66 to 76 years, and the percentage of non-Hodgkin lymphoma deaths is highest among this subgroup of age among 75 to 84. So we have to do something in order to improve the outcome in older patients with non-Hodgkin lymphoma. With this regard, the International Society of Geriatric Oncology, the SIOC, has published a lot of guidelines coming from different task forces, and there are 2 specifically for diffuse large B-cell lymphoma in older patients. Both of them were published in 2015. The first one is related to the impact of prognosis, comorbidities, geriatric assessment, and supportive care that we can implement in our daily clinical practice when we see a patient with aggressive lymphoma. And the second one is the approach to therapy. How can we tailor therapy in our older patients? So what can we do when we see a patient in our clinic? First of all, we have to distinguish between these different concepts. Comorbidity is not the same as frailty. Comorbidity is the concurrence of the presence of 2 or more medically diagnosed diseases in the same patient. And frailty is different. It's the state of high vulnerability to adverse health outcomes, including but not only disability, dependency, falls, need for long-term care, and mortality. And it is also different as disability, which is the difficulty or dependency in carrying out the activities of daily living. So we have to distinguish among these concepts in order to look for the best tool to assess them. How can we assess comorbidity? We have 2 different tools. The first one I'm going to introduce you is the SIRS scale. SIRS stands for Cumulative Illness Rating Scale, and the second one is the Charlson Comorbidity Index. The SIRS scale is going to assess 14 items of organs and system, and we are going to score from 0 to 4, depending the severity of the comorbidity. It has been very well studied in other hematological malignancies, such as chronic lymphocytic leukemia, but it's less studied in patients with diffuse large B-cell lymphoma. I want to show you some preliminary data of our institution, where we have analyzed the impact of the CSG in the outcome of older patients with aggressive non-Hodgkin lymphoma treated from line with R-CHOP-like regimen. And as you can see here, if the score is less than 6 points, the median overall survival was not reached in comparison with only 25 months in patients with a high comorbidity score, which is over 6 points. The second comorbidity tool that we can use is the Charlson Comorbidity Index, but it has not been studied in patients with any kind of malignancy, because as you can see in the slide, the malignancy by itself is going to be included in this tool, so it's not recommended to use this one, and it's preferable to use the CSG in patients with any kind of malignancy. If we move to assess frailty, we have two different screening tools, the G8 and VERS13. G8 stands for Geriatric, exploring 8 items, and as you can see, we can ask these 8 questions to our older patients in the clinic, and it's going to take only 2 to 3 minutes. We are going to ask the patient about the food intake, the weight loss, mobility, dementia or psychological problems, body mass index, polypharmacy, and how the patient is feeling when if it's compared with other people of the same age. So in only 2 or 3 minutes, we are going to have this very useful information. This tool was developed in cancer patients, and it has also been explored and validated in patients with hematological malignancies. In this study, over 100 patients were analyzed, including patients with aggressive lymphoma. 1/3 of them had this hematological malignancy. And as you can see in the Kaplan-Meier curve, patients with a normal G8 score that receive a standard therapy were going to have a very good outcome in comparison with those patients with a normal G8 score, but that they were treated with a dose reduction, or treated was omitted only because of the age. The outcome was going to be as poor as if the patient was treated with a standard therapy and was identified as frail with an impairment in the G8 score. The other screening tool is VERS13, that stands for Vulnerable Elderly Survey. It's a different screening tool. This is more commonly used in the United States, and it explores different domains. As you can see, we can ask the patients about tasks of activities of daily living and instrumental activities of daily living, and we can see if the patient needs help in things like shopping, money management, life, housework, transferring, bathing. So we are going to have more information using this screening tool. And this is also very interesting because it can be self-assessed. So patient can fill this questionnaire before coming into our clinic, so we can have both information before we see the patient and we decide which treatment we are going to offer him or her. These tools are screening tools of frailty, and they are going to tell us if we should or we must refer the patient to the geriatrician for a full comprehensive geriatric assessment. The geriatrician is going to explore 8 domains. As you can see, functional status, exploring activities of daily living and instrumental activities of daily living, comorbidity, mental status, emotional condition, nutritional status, polypharmacy, and the onset of geriatric syndromes. Finally, the geriatrician should write a report and should classify patients into 3 different frail phenotypes according to Balducci's classification. The first one is robust patients, which are fit enough and who may benefit from a standard cancer treatment. an intermediate group called vulnerable patients that are still fit, but they need to reduce or to adapt the healthcare to treat the malignancy. And finally, the poor prognosis group, also called as frail, that benefit only to receive palliation. So how can we implement or how can we translate this geriatric assessment into older patients with aggressive lymphomas? If we see this treatment algorithm proposed by Jonathan Freitberg several years ago at an ASH meeting, we have a first time of curative intention when we treat patients frontline with an aggressive non-Hodgkin lymphoma. Early this year, in May 2018, ASCO published these guidelines in order to help us to decide the therapy in all of our older patients with any kind of malignancy and, of course, aggressive lymphomas. And ASCO recommends us to assess for the prediction of chemotherapy toxicity using these two validated tools, CAR-G and CRASH. The estimated non-cancer life expectancy using ePrognosis, which is a free access web-based tool. It recommends to assess functional function using instrumental activities of daily living, comorbidities, and screening for falls, depression, cognitive impairment, or malnutrition. So if we can assess all of these domains as much as we do, the better. But if we cannot do all of this assessment, at least try to do as much as we can. SIOC recommended us to assess comorbidities in older patients with aggressive lymphoma in order to avoid treatments that can impair or worsen the previous comorbidity condition. For example, we should avoid anthracyclines in patients with previous cardiovascular disease. We should avoid platinum derivatives in patients with renal dysfunction, and vinca alkaloids in patients with previous neuropathy. And when we explore the different clinical trials specifically designed for older patients with aggressive lymphomas, you can see that the addition of rituximab in the CHOP regimen, that is R-CHOP, is going to be the best regimen to treat our older patients with aggressive lymphomas. And if we compare the regimen R-CHOP 21 versus R-CHOP 14, they are almost the same, with higher toxicity in patients receiving the dose-dense R-CHOP 14. So the standard of treatment for older adults with aggressive non-Hodgkin lymphoma remains R-CHOP 21. These are data from the Spanish lymphoma group. We conducted a retrospective study. We enrolled almost 250 patients with an age above 80 years. You can see the range among 80 to 100. And in the right side of the slide, you can see that almost one half of the patients were treated frontline with R-CHOP, and they received rituximab and anthracyclines or in the first or in subsequent lines. And we developed this score. We identified three prognostic factors in older patients with aggressive non-Hodgkin lymphoma: age above 86, a SIRS score above 6, and an IPI of a high risk. And as you can see in the Kaplan-Meier curve, patients with a score of 0 or 1 point are going to have a better survival, with a median overall survival of 45 months in comparison with only 12 months in patients with 2 or 3 poor prognostic factors. And following with these prognostic factors, our Italian colleagues from the Italian Lymphoma Foundation published 3 years ago this very interesting study. We do not have geriatricians in all of our academic hospitals, and they proposed the classification into the 3 frail phenotypes, but only assessing activities of daily living, instrumental activities of daily living, comorbidities, using SIRS-G and the age subgroup. And in the multivariate analysis, you can see that only the IPI and these short comprehensive geriatric assessment impact in the overall survival of the aggressive lymphoma patients. And if we see the overall survival, it's very interesting to see that patients identified as fit, despite of the age, are going to do very well if they receive a curative therapy in comparison to those fit patients treated with palliative intention. This difference is also seen in the intermediate group, despite it's not so much impressive, but another piece of information very relevant in this study is in the frail group. In this subgroup of patients, the outcome is going to be the same if we treat the patient with a curative approach or with a palliative therapy. So if a patient is considered of poor prognosis, at least do not harm and treat only in a symptomatic way. What to do in very elderly patients with 80 plus? We can give a reduced dose of R-CHOP in the also called R-mini-CHOP. As you can see, the dose of rituximab is going to be the same, and we are going to reduce the dose of the other drugs. And the median overall survival of this mini-CHOP study was 25 months, and the 2 years overall survival was almost 60%. And also, it's very interesting to see that the IPI remains very important to assess prognosis in older patients with aggressive diffuse non-Hodgkin lymphoma, the diffuse large B-cell lymphoma. But also, the investigators identified two other prognostic factors. In the middle of the screen, you can see the serum albumin that can translate an impairment in the nutrition. And in your right-hand side, you can see again the functional status. The instrumental activities of daily living is going to predict the outcome in older patients treated with R-mini-CHOP. And we see, following this treatment algorithm, that almost 1/3 of patients will eventually relapse, but we have still a second chance for cure if patient is transplant eligible to proceed to high-dose chemotherapy followed by autologous stem cell transplants. ESMO guidelines recommend us to give to eligible patients for transplant a platinum-based regimen like DHAP, RIs, or RGDP, and proceed to autologous stem cell transplant. And for those patients not eligible for transplant, a platinum and or gemcitabine-based regimen. Is autologous stem cell transplant feasible in older patients with aggressive lymphomas? Yes, it is, but we have to select very well which patients are fit enough to proceed to high doses of chemotherapy followed by the autograft. And in this study, you can see data from 3 different trials exploring autologous stem cell transplant in patients with non-Hodgkin lymphoma, and the non-related mortality is around 5%, which is almost the same as the one that we find in younger patients. But of course, they are very selective, and we need to identify these very fit patients that can benefit from this strategy in order to cure in a second chance. It's very important to know that if we are not going to proceed to the autologous stem cell transplant, we should not offer the patient an intensive therapy like DHAP. They are going to have a very good response, but it's not going to be long-lasting, as you can see in the event-free survival coming from the PARMA trial. In the second-line therapy, in those patients that are not candidates to proceed to autologous stem cell transplant, there is no standard regimen. The overall response rate range among 55 to 75%, and the CR rate ranges from 25 to 72%, with a very short progression-free survival between 6 to 12 months. Again, there is no standard therapy. We can offer a patient oral regimens like PEP-C or CEPP, or gemcitabine and platinum-based regimen like GDP or GMOX. And now we are seeing some data about using lenalidomide or bendamustine in second line in patients that are not eligible for transplant. Regarding the GMOX regimen, here are data from the Spanish group. We have a median progression-free survival of only 5 months and median overall survival of 11 months. And regarding bendamustine, it's very interesting because, as you know, it's not so toxic regimen, but we have to take into account that the doses of bendamustine that we have to give to our patients with aggressive lymphomas is around 120 to 150, so it's much higher than the one that we give to our patients with follicular lymphoma or CLL. And with these doses, you see that it's not as feasible as we can imagine, because only 16% of patients could complete the 6 planned cycle. And the outcome is going to be different regarding the scenario that we are going to give bendamustine. If we give our bendamustine in patients with 3 previous lines of therapy, the overall response rate is going to drop from 73% to only 25%. It's overall response rate, not CR rate. And we are going to have different outcome regarding the time of relapse. Patients with early relapse, that is a relapse within the first 12 months, the overall response rate is going to be the half as if we give this regimen in patients with late relapses. But this regimen is very attractive because we have very preliminary data of this phase 3 trial presented this year at ASCO, where our bendamustine has been combined with a new conjugated monoclonal antibody, which is polatuzumab vedotin, which is a monoclonal antibody against CD79B. And as you can see, the best overall response rate increases from 33% to 70%, and the CR rate rises from 20% to 58%. And if we see the survival of these patients, the combination of polatuzumab with our bendamustine are going to improve both progression-free and overall survival. And I want to conclude showing and sharing with you the patient's journey in our lymphoma unit in Fundacion Jimenez Diaz, in my institution. When we see a patient with 70 years of age or above, the hematologist or the oncologist is going to record the past medical history, and the hematology nurse that has been trained to assess the G8 and CSG is going to assess this screening and comorbidity tools. And those patients with a G8 score less than 14 points are going to be referred to a geriatrician. The geriatrician is going to perform a comprehensive geriatric assessment and is going to calculate the life expectancy outside the malignancy using the ePrognosis tool, and is going to classify patients into robust, vulnerable, or frail. And we are going to present the case in the lymphoma tumor board. And in this multidisciplinary meeting, we are going to decide the treatment plan. For those robust patients, we are going to prescribe the standard therapy. For those vulnerable patients, we are going to give an adapted therapy. And for those considered as frail, we are going to refer to palliative care. Finally, the oncology pharmacist is going to assess polypharmacy, drug-drug interaction, and is going to monitor adherence in patients that are going to be treated with oral antineoplastic drugs. And finally, in the follow-up, the hematologist, oncologist, and the nurse is going to assess for quality of life and patient-reported outcome. So my take-home messages from this first talk is that there is an increased incidence of non-Hodgkin lymphoma in older patients. We need to identify the very fit older patients with aggressive non-Hodgkin lymphoma that can be benefit from a full standard dose of R-CHOP, which is the curative approach for all of patients with diffuse large B-cell lymphoma. In the relapse setting, there is a second chance for cure in this very fit subgroup of patients that can proceed to autologous stem cell transplant. But for those transplant ineligible, maybe the duration of response would be even more important than the CR rate. In those frail patients with very poor prognosis, at least do not harm, because the treatment with a curative approach is not going to prolong survival. And I want to highlight that we have tools to assess comorbidity and frailty in all of our patients with not only aggressive non-Hodgkin lymphoma, but in patients with hematological malignancies that may help us to adapt therapy in this subgroup of patients. Thank you very much for the attention.